All right, welcome everyone to our free monthly webinar series with AHA Team Training. My name is Rachel Vandervoort. I'm a program specialist here with AHA Team Training, and I'm very excited to introduce the thin blue line, drifting reliably towards a safety culture. It's going to be a great presentation today. We have two excellent physicians who are going to walk us through some concepts and ideas. And yeah, I'll get to their details in a moment. But first, let's go over a few rules of engagement. Oh, one slide too far. Rules of engagement. So we do recommend using your computer audio. You can also access by phone. There are instructions on how to do that. Please note that you are in a listen-only mode, but the hyperlinks you see on your screen are live, so feel free to click those when you see them. The chat will be active throughout the presentation. Feel free to chat in questions as you think of them. If they are of a technical nature, we will provide immediate assistance. If they're more about the content of the presentation, we will likely save those for the Q&A at the end. But don't worry, I'm scooping them up and the presentation presenters will take a look too. So yeah, CE credit is available for those that are attending live today. In order to get that credit, you do need to have a Duke OneLink account set up with the instructions provided there. In order to receive that credit after the presentation is over, text that code to the number provided on the screen there. You have 24 hours to get that in. And then before we get to the content of today, just a few reminders about upcoming team training events and offerings. We do have in-person master training courses coming up in the next few months. Very excited to be hosting one here in Chicago at our AHA offices. Not only will you get to meet the AHA team, but we also have our Chief Physician Executive, Dr. Christy Rienzo, as part of the course faculty. So that should be exciting. Our virtual course kicks off next week. There are a few spots left there. So if you're interested in doing an 8-week virtual course, I would snag one of those. And then we will have a webinar next month on May 8th, same time as usual. We're just getting all the final details from our presenter to get that up on the web. If you have something that you would like to share with our community via webinar, we do have a speaker interest form. Fill it out. We'll get back to you and let you know what next steps are. But our webinar program really is about our community. So let us know what ideas are valuable to you. And then also, in addition to our public courses and free webinars, we do a lot of customized consulting and on-site training with health systems, hospitals, teams of all sizes. This is a really great way to get very tailored support, very tailored approaches, and get experts down in the nuts and bolts of what you're hoping to achieve. So again, reach out to us. We would love to talk to you about it and provide solutions for you to consider. So don't forget that in addition to all the other things, we can come to you. So without further ado, I'm going to turn it over to today's presenters. We have with us today, Dr. Chris Lemaster, who is the Northern California Physician Safety Lead for Kaiser Permanente. And we also have Dr. Jason Chang, the Medical Director of Safety at the Permanente Federation. So with that, I turn it over to you.
Well, thank you so much, Rachel. And Jason, I know, agrees. We really, really appreciate you joining today. Let's just get right into it. So these are the objectives for today. And the first here is understanding the difference between work as done and work as imagined, and why marrying these different perspectives is very powerful for how we and our organizations can succeed. Number two is operationalizing our frontline teams, really depending on them to help us figure out how to engineer resilience in the system. And then finally, to develop a different kind of understanding about drift. We're sort of playing on that word drift here. It's dynamic, it changes over time, it doesn't necessarily mean the thing that we think it means. And so we're going to unpack that a little bit later. Jason's going to go over that. Okay, so we're going to start off with a case, a story. This is a child who comes into your emergency room. Mom brings him in. He's got a fever and she's concerned. The nurse at triage checks the vital signs, weighs the child, enters this into the computer, and the child's brought back to a treatment room. And he's got a fever, so the doctor orders some ibuprofen. Um, the nurse draws it up and gives it. The fever is treated, it goes away, the child's feeling better and is discharged home. And that's basically the story. Now, the discharging nurse notices that the dose of the ibuprofen was too high and reports this to Tina, the ER nurse manager. Tina learns about this the following day and needs to make a choice about what happened. It appears that the child received a 2.2 time overdose of ibuprofen. And perhaps there was something about the nurse measuring the weight in pounds and entering it into the computer as kilos. I'm curious for those of you listening, which I hope is all of you, what do you think is going on here? What, as an ER manager or a risk director or whatever your role is, what's your explanation for what happened? What's the cause? If you could just type something into the chat, wait a few seconds to hear from you all. Seeing human error, education, human error, took a weight that was in pounds, distraction, equipment issue, could be system setting. Lots of great answers here. Okay, so what did happen? What did Tina do? Before I go into that, I want to first talk about some of the key points for this webinar, set the context, and then we'll weave in this case as we go through. So the first, we all already know this to be true, which is healthcare is complex. And in fact, safety events are pervasive. If you work in a hospital, you see these happen every day. The second is that focusing on our people, relying on them to be perfect, isn't working, right? That's what we try when we do education and we ask people to follow standard work and policies and procedures. Those things are necessary, but they're not sufficient. And then finally, focusing on human error will make people feel blamed. And I'll unpack this a little bit because this seems perhaps surprising. But if we rely on people to be perfect, we will be disappointed a lot because people are not perfect. It also makes people feel blamed, which undermines our learning undermines learning, and it undermines a safety culture. But it's not all doom and gloom. We can still solve many of our thorniest problems. It kind of seems like we've picked all the low-hanging fruit already. We can't make people more reliable. That would require genetic engineering. What we can do is we can make the systems that support our people to be more reliable. Things like system safety engineering and design. In fact, there's a lot of low-hanging fruit. It's just that we've been looking at the wrong trees. So where do we look? Well, I think step one is that we need to look inside at ourselves and think about how we're understanding these events. It's about changing how we think about healthcare safety. And I'm going to focus on two specific ideas. The first is that our staff are not our problem. They are our problem solvers. And the second, and if you're going to remember anything from this talk, remember both. But if you only remember one of these, just remember the bottom one, which is we can learn or we can blame, but we can't do both. We have to make a choice. And the good news is if we can shift our mindset there's an enormous opportunity for learning, for growth, for improving safety that's hiding in plain view. So let's go back to our case. What did Tina do? Tina is a very brilliant nurse manager, and she understood that sometimes staff need to blame. They need to react before they can respond. And so she asked a few of the nurses and doctors on shift the following day what happened and what their view was. And they basically blamed the triage nurse for entering the weight incorrectly. Should have slowed down, should have paid attention, should follow proper procedure, etc. Um, it gets even more interesting than that because the physician who ordered the ibuprofen received a pop-up warning about the weight that they overrode. The nurse giving the medicine had to drop more than one syringe, which even the mom questioned. So you might think, wow, like really people were not paying attention. I think Tina's brilliance was in understanding that desire to blame, it actually serves a need for us, that we need to discharge our own emotional energy when something bad happens. And before we can learn, before we can kind of go behind what looks like a human error, we have to first kind of process that. So she did that, and then she said, okay, let's get curious. How do we respond? What can we learn? And so she went and talked with the triage nurse and discovered something amazing, which only the triage nurse could tell us. And that was the scale that they were using measures in pounds and kilograms. They used to have a scale that only measured in kilograms. What this highlights is that there's something about the environment, the designed environment, that influences our behavior and leads to these kinds of events. Tina, went around the ER, found the three scales that we have, one of which was a kilos only scale, and immediately brought that to the front. So already removed this scale. And then within about 5 minutes, a charge nurse was able to look up a YouTube video on how to lock this scale into kilos only. And so all three scales were now kilos only scales. This all happened because Tina was thinking about this problem differently. She was thinking about her nurse, who we could say had committed a human error and we should re-educate, but sort of thinking beyond that. How do we respond? What can we learn? Let's see that nurse as an expert. This ultimately, and I think this is, in my mind, the most important thing. If we want to change healthcare safety, we need to think differently. We need to change how we think about this problem, our mindset, how we frame what we see in the world. It affects the kinds of conclusions we draw and therefore the actions that we take. This is, a very benign example, but do you see a rabbit? Do you see a duck? If we're talking about events, do you see error, or do you see a system that's setting up nurses with an error trap that almost anyone in those conditions would make? If we can shift our framing here, it'll positively influence everything that comes next. Okay. Now these ideas come from somewhere. These aren't mine. Some of this comes from research by people like Eric Hallnagel, Sidney Decker, a man named Todd Conklin, who was a safety advisor for the Los Alamos National Laboratory. He did a great job of consolidating many of these ideas into what he calls human and operational performance. And as you can see this circle here from the Chevron oil company, there's a guy there named Bob Edwards who had enormous success spreading this idea of human and operational performance throughout Chevron. And in fact, this approach is used throughout the oil and gas industry in the United States and is starting to spread into other industries, Tesla for one. We haven't used it much in healthcare, although at Kaiser we've been working with this idea. Let's unpack these 5 principles that are outlined, and I'll weave in the case that we have been talking about. Number 1, error is normal, which is a kind of a profound statement. It's not just human, it's normal. Human beings are error-prone individuals, this is how we learn. We try things and experiment. And when we make mistakes, that allows us to figure out how to interact differently in the world. The problem isn't that we have a bunch of dumb humans and if only they stopped making mistakes. It's actually that we've built systems reliant on people not to make mistakes when in fact that's what we do all of the time. You know, how many times do you think a nurse accidentally transcribes a weight measured in pounds into kilos in a computer in hospitals across the world? I mean, that probably happens all of the time. We could try to retrain every one of those nurses, but an alternative is we could look at something about the system and change it, which will be far more effective in the long run. You know, transcribing is something that humans do not do with 100% reliability. So why have we built a system that relies on them to do that with 100% reliability? Okay, number 2 is that blame fixes nothing. The other way I like to frame this is blaming Joe. You know, it's kind of fun to blame. When something bad happens, again, we feel awful. And if we can find somebody to focus on, that'll discharge a lot of our own emotional energy. But I think Tina had something right here. There was something brilliant about her way of framing this, that sometimes you need to kind of go through the process of reacting and blaming, like the nurse and doctors did, focused on the triage nurse, before you can learn. You could try suppressing that, but sometimes that's really hard, especially when the event's awful. The third is that systems drive behavior. And I'll explain with our case. This is far more impactful than the humans working in our system. It's the systems that surround them. This system, the scale, allows the nurse to measure in pounds or kilos. That's a failure mode that exists, that's inherent in this scale. Now, imagine if we had a different design where it only measured in kilos. There would be no opportunity to accidentally transcribe the number incorrectly. So again, the design of our systems really matter, and we need to change our mindset to think differently about how we see the world. Okay, now we talked about in the title, the blue line, and I'm going to unpack that now. This is fundamentally about how we look at our staff. And it starts with understanding the difference between work as imagined and work as done. This black line represents work as imagined. This might be a policy or a procedure, or if you're a manager or a director or in the C-suite, you have an idea of what work looks like on the ground. But if you're not actually doing the work every day, your representation isn't an accurate reflection of reality. Reality looks like this. These are workers whose work on a given day is highly variable because there's all kinds of complexities, ambiguities, production pressures, goal trade-offs that are happening, and it changes every day. And they are your experts. They're your problem solvers because they're the ones that figure out what to do when the resources don't fit what the policy says should be done. They are, in fact, the masters of the blue line. Another way of framing this is work as imagined versus work as done as a Venn diagram. And you know, a little bit later, Dr. Chang is going to talk about drift. And often what we see after an event is that somebody didn't follow policy, and we call that drift. I think a lot of the time what that actually represents is that the policy that's written or the standard that we think should be followed doesn't accurately reflect reality, that it's not designed with the perspective of our frontline staff, our frontline nurses and doctors who can tell us whether that design will work or not. The goal here is to make this Venn diagram overlap perfectly, and that requires ongoing dialogue between our frontline and everybody else. Another way of thinking about how we engage with our staff, work is done, is through empathy. And I think many of you are nurses, and you have a kind of emotional intelligence that most people don't. It's a superpower. It's what brought you into this field for many of you. We need this when we're going into an event and trying to understand what happened. As Sidney Dekker says, we need to go into the tunnel to see the complexity, the uncertainty. It's dark in there. They're muddling through. They don't know what's at the end of the tunnel. They don't know what's going to happen. You'll know that you've spent enough time understanding an event when it makes sense to you why your staff did what they did, given the conditions they faced. Okay, number 4, learning is essential, and I've already gone over that. It's this: we can learn or we can blame, but we can't do both. When we listen to the triage nurse and learn about the pounds kilo issue, this can impact us very positively, right? We can think about locking these for every hospital in our system, or about what kinds of scales that we procure in the future. But none of that is accessible if we focus on the nurse. The final element here is how we respond truly matters. And there's a bit of navel gazing that needs to happen, some self-reflection. Do we react or do we respond? Remember the duck rabbit, how we see things really matters. There's several elements to this. The first is hindsight bias. We need to check that. It heavily biases us, often in unconscious ways. When something bad happens, we tend to oversimplify the sequence of events, not understanding the ambiguities, what it's like to be in the tunnel. And this prevents us from listening to our staff. In reality, the difference between success and failure is only visible in hindsight, right? If you're watching work happening, success and failure looks the same. The outcome is the only way to differentiate the two, and that's something that your staff never have access to. It's only us looking at the event after the fact. There's a lot of talk about psychological safety, and it's critically important. First, I think it's important to understand that we as leaders can create psychological safety, not by telling our staff to feel psychologically safe, to feel safe speaking up, but for them to actually feel that. What are the conditions that we need to create for them to feel safe, to build trust? And I think we can build a virtuous cycle when we see our frontline staff as experts. We listen to them, we help them solve their systems problems, and that motivates them to speak up again. We might even reward them for speaking up, even when the news is bad. If we can create that, then we build a virtuous cycle. Psychological safety is also, it's not kumbaya, holding hands, everything's great. Sometimes it's heated exchanges or debate. It's important that people can disagree, but respectfully, and learn from each other. It tends to grow in places where people are willing to listen, but reactive blame can erode months or even years of time spent building it up. And if we can build that virtuous cycle at scale, this may affect hospital mortality. This was a study that was done in England of 137 hospitals. And what they found is that their measure of psychological safety, their standardized openness score, was associated with reductions in hospital mortality. In other words, the more psychologically safe that your staff felt, the lower the hospital mortality. Now, this is an association. We can't prove a causality here, but I think this highlights a really important relationship between psychological safety and the things that matter most to you and your patients. So on one slide, these are the five points. Number 1, error is normal. Number 2, blame fixes nothing. Number 3, systems drive behavior much more than the individuals working in them. Number 4, learning is essential. We can blame or we can learn, but we can't do both. And number 5, how we respond matters. Again, remember that how you and I are thinking about these situations matters, and listening to our staff is critically important. We can blame or we can learn. And our staff are not our problem. They are our problem solvers. Okay, with that, I'm going to hand it over to Dr. Chang. Thank you so much.
Thank you so much, Chris, Dr. Lemaster. First and foremost, are you able to hear me? Okay.
Yes.
Oh, thank you. I never assume anything. So all about that closed loop communication. Let me go ahead. First and foremost, let me share my screen. That probably would be good for me to do. Let me share my screen here. So we're literally kind of handing over the control of the plane from one pilot to another. Let's hope I don't end up sending us in the wrong direction. So let me just take a quick look. So we can learn or we can blame, but we can't do both. I think that really speaks a lot to why I found this a riveting discussion. I'll talk about the blame aspect of it, and definitely our staff are problem solvers. So um, I wanted to really take what Chris had discussed into a broader context of how and where I think we really are in healthcare. I'm very, very proud, of course, our organization that Chris and I both belong to, working with the Kaiser Permanente, as our physician leaders. Huge shout out to many of our participants who I know are calling from our Kaiser regions from Hawaii all the way out to the East Coast. But really, when we think about the journey, of patient safety, I think we frequently begin or initiate this journey through the 1999 Institute of Medicine report, To Err is Human. And I really am going to preface so much of really, I think, our journey through that notion of err, because obviously erring and human beings and blame, and how does blame or how does our ability to look past blame, and really the notion of drift, which is just another way of calling blame, how it affects our ability to be able to be a learning organization and a learning mindset to become safer, obviously. If you look at 1999, you say, okay, well, that was a long time ago. We're in 2024. Maybe it's been a while. We probably have improved. Well, this is actually a report from the Institute of Medicine, and it was actually a statement that I think really speaks to really how much we've moved or maybe haven't moved. And the statement was, I think that much of the work that we have done has not focused as much on the environment, but on individual programs and interventions, still at the individual level, rather than the systems level. I fear that without a focus on the organizational level, we should only expect marginal gains moving forward. So that's rather a bit of a wake-up call, saying 17 years. And of course, we had this thing called the pandemic that may have put us back a little bit. So we're really trying to reemerge and try to understand really what is it maybe we have not done well that we need to do better. Um, Today, I'm going to probably take you through, some themes, from different experts, in the field of patient safety. Many of you, probably, hopefully all of you do know Professor James Reason. Fantastic book right here. I have no disclosures, by the way, to all the books or people that I recommend. But one of the things I think very personal to me, especially as a physician, and try to really understand, how the notion of blame affects is really this quote that Professor Reason really says. After an arduous and expensive education process, you are expected to get it right. You are expected to get it right. So I feel like my room for making a mistake isn't there's not very much room. And consequently, errors are stigmatized and equated with incompetence. So the stigmatization part, I think, is something that bears very much within the psyche of our professionals who spend all their time really doing the and really incompetence. So let's think about blame, for a second. I wholly apologize to our cat fans here. My point really showing how much blame is really built within the psyche of everybody, including our felines, as well as our canines, and probably every other animal out there. But even beyond from a species, you can see obviously this is baked even into the way our organizations sometimes may think about blame. To err is human, to forgive is against company policy. Oh my gosh. Okay, so obviously it is a little bit of a joke But in terms of the whole blame theme, and here's my full disclosure: as an anesthesiologist, I was just curious. I've always been told by everybody, at the end of the day, just blame anesthesia. Case got canceled, blame anesthesia. The operating room started late, blame anesthesia. Patient moved, blame anesthesia. So there's a running joke. So I kind of Googled uh, blame anesthesia, and this is what I came up with. So keep calm and blame anesthesia. So it's actually one of our jokes, actually, that because we probably were filled with so much blame, my field is one of the fields, actually, I think, very proudly, began and was a part of the patient safety movement. So a little bit of a joke right there, but really talking about the importance that blame does have. This is a fantastic book. I recommend everybody to get a chance. Now, Matthew Syed is not one of our psychologists, with patient safety, but he really talks about the psychology of blame, the psychology of what it really takes to learn, but why frequently, people and organizations, institutions, religions don't. This is a fantastic quote, I found in his book. We will see that blame is, in many respects, a subversion of the narrative fallacy. It's an oversimplification. So I'm going to use that word very frequently: oversimplification driven by biases in the human brain. We will see that it has subtle but measurable consequences, undermining our capacity to learn and to find resolve from the pain we create for others and ourselves. Really very powerful, meaningful quote. So when we're really thinking about, the oversimplification, when you're thinking about healthcare in general, I mean, healthcare has a social aspect of it. Those are the people, those are the cultures, those are the subcultures, and the technical system, all the different facets of our healthcare delivery system that have to work and put all this together. How can any of this ever be considered simple by any stretch of the imagination? You're seeing how a process, or maybe a protocol, or maybe a policy up on the top left end can potentially drive and has an interconnected web with so many of the other areas. We're looking at outcomes sometimes. Maybe we're looking at supply chain with equipment, supplies, and costs. So I think you get a sense from this picture just really how complex our systems are, which is the reason why how we react when we learn about things is so critical for us to be able to learn. Now, I'm going to take you from that very complex social system to this picture. This is actually in Amsterdam. Normally, Amsterdam is our beautiful city of canals. And once every few years, it gets so cold from the Siberian tundra that comes over, that part of Europe, that the lakes actually freeze over. So this is a wonderful picture. Everybody's out there ice skating, have a great time. That person looks like he's taking a picture right there. And the reason why I'm showing this picture, because this picture is going to very powerfully illustrate really what we would consider what are the boundaries of safety, what are the margins of where we become unsafe, and also really thinking about drift in terms of how different people, how our perceptions about how confident we are drive behavior that can lead us towards safety or unsafety. So this is a picture I really wanted to share. Now, if you're sitting here, you're looking at this the way I'm looking at this, I'm like, my gosh, these people are crazy. They're skating on water. But if you're there skating, you're having a great time. You're taking pictures, you're holding hands. And really, there is no way for you to be able to know if you're actually skating what is truly a safe or a thick, strong part of the ice, but also what is the part of the ice maybe you shouldn't. Maybe you're just not that great of a skater. Maybe you don't have that information. Let's take a look at a picture about, that actually illustrates kind of what I'm actually going to explain to you here. So take a look at this video. Oh, all right.
That looks like it hurt.
I think he looks like he may have done this before. Thank you, Chris. Let's go back to that picture again. I'm actually not going to go for it. I'm going to go backwards for a second here. So that obviously, from hindsight of us looking at that gentleman, or maybe other people evaluating his, what I would call reckless behavior, seems completely, he's completely reckless, in terms of what his behavior was. But we have no idea, really what his skill sets were. We have no idea that maybe he had some knowledge about it. All we can do is judge him as a person using our natural fundamental attribution error to just say he is a complete idiot. But the problem is when you're on the ice, how do you know which parts of the ice are safe and which parts of the ice are not safe, other than just by judging under the conditions and socially what's happening in those conditions at that time? So I'm not going to show this. So now I want to go from that nice little frozen lake illustration to talking about the notion of what's called boundaries of safety, because obviously that canal kind of illustrates a very powerful point when we're thinking about drift and when we're really thinking about what safe behavior is. This is an article written about a famous organizational psychologist who really studied safety. One of the authors, Chris Lemaster, Chris actually co-wrote, I believe, an article with Robert Weirs, really kind of talking about, drift, which you see right there. But look at the other word next to Rasmussen's name, dynamic. And that's something I really want, I think, us to think is how to rethink about a term, but in terms of a broader context of what's actually happening when you're looking at a dynamic situation in a complex system and how boundaries actually play into that. So here's a picture I really want to just initially show you. I'll get a little bit more into this notion of these different boundaries and how they shape the way that we think about drift and actually how they gear us towards really moving towards a just culture. So I'll talk about a little bit about just culture toward the end, how this leads into all this. What I wanted to just kind of give you an idea. When you're working in a complex system, there are actually implicitly specific boundaries that we individuals, but also as a group, really have to work collectively. Let's just think about this as from an individual standpoint, because I'm going to start to move this towards as we're thinking in terms of a group and a larger dynamic. On one boundary you have right up there, okay, again, think about that frozen lake for a second. You have the boundary of economic failure. You have to keep the lights on. You have to pay your staff. We have to be economically viable and successful to be a business. We have to be solvent. So that is one boundary that will actually drive us in one direction. So that's going to be that arrow, that gradient towards economic efficiency. You would imagine that that boundary is going to push you without any other counterbalances in a direction that would just keep moving forward. Now, on the other hand, on the opposite end of this, with that dark brown, you have boundary of safety regulations. This is what you shouldn't be doing. These are the things that, you would think help push back against it. So there is a little bit of this counterbalancing pressure. Sometimes we call them competing priorities. And that's all basically the gradient in which all these factors exist. And of course, the dark blue line you see is the boundary of unacceptable workload. So you want to be as successful economically as you can, but you also have to make sure you're not basically pushing people or systems in a way in which actually it's not tenable. So there are these fundamental boundaries. And you see that really, like that ice that you see, different parts of those boundaries have different levels in which safety can exist before you start to stress too much of it. Is some parts of the ice thinner and maybe only one or two people can be there? Maybe that's where that guy skated off to, right? Are there parts of it where maybe it's a little stronger and safer, and that's why you want to make sure more people are safe, skating over on the safe side? Now, look what happens, however, if you are not conscious of the boundary of those safety regulations and you start pushing too far, then you start getting into that red dashed area. And frequently when we were looking at safety events or sentinel events, this is when the accidents come. We realize maybe we've been out here just like the guy falling through the ice, but didn't realize it. And is it really a fault of the individual, or is it really more understanding the conditions of the ice, the temperature, maybe the humidity, maybe the kind of ice skates he was using, who knows? Those are all things that factor into it. So really, this is when we're moving to what's called the boundary of functionally acceptable and unacceptable behavior. Now, This is the actual pictorial I kind of want to share with you. Kind of the same things. You have the economic failure boundaries where management pressure is going to push you towards efficiency. And of course, below that, you see the unacceptable workload boundary. These might be your ratios of, number of nurses that are able to see a certain number of patients. So there is that boundary that also exists there. And that's going to push a gradient. But then if it's the opposite of it is toward the leftist effect. So you're always sitting there somewhere in the middle. Then you have the counter gradients from campaigns for safety. That would be for all of you who are doing your safety work, making sure we're, using all of our systems, and that pushes into it. Then you have something very important that I want you to look at. The most important thing I want you to see in this picture, it's that dashed line. It's that marginal boundary. That marginal boundary sometimes moves, sometimes is the last thing anybody ever pays attention to, but it's the most important area to fundamentally think about when we're really thinking about drift, because drift frequently ends up becoming that term of attribution we use when we've realized everybody's moved too far into that other boundary. This is when we have that boundary and understanding what that margin is, we have what's called the acceptable performance boundary. Now, if we extrapolate this a little further out and think from an individual lens now to maybe an entire unit, maybe to an entire institution, maybe your organization, maybe your hospital, it might be just a single unit. And what you see now is when you're now thinking about these different boundaries, you may move around in these different areas. This is the drift. The true drift actually is not so much that there is somebody who just, went into some unacceptable boundary, but the drift is really a dynamic flow and how the conditions move you around within these boundaries, just like that lake. If you look at, the quote unquote safe zone, which really I don't think very many, areas have in our, current environment. A stable, low-risk system stays far from boundary of acceptable performance. Okay, so that would be kind of that area. It's kind of shaded right there. If we go up to now, if we look at the bottom with that much bigger gray circle, we have unstable system. This is an LRO, what we call not a high reliability organization, but a low reliability organization, because you could see what it is. It's operating near the margin. It's coming into that unacceptable workload area. The operating is near the margin and the operating point moves over a wider area. So it's an unstable system because it isn't really moving within that operating point, and it's moving very close to that acceptable performance boundary. Now, if we look at the top, when we talk within the context of high reliability, this is where it's stable. It is a high risk system. And I would venture most of the systems we work with within healthcare are high risk. So we are actually very close to that boundary. Operates near the margins, but with tight control of an operating point. So I just want you to realize when we're thinking really about drift, it really does move around in a very dynamic capacity. One unit, let's take the ER, for instance. Dr. Lemaster works there, obviously knows about, just how much, movement there is within, his area of work. Imagine the difference of how this moves when it's maybe a stable, quiet day versus a crazy Saturday night after a, Golden State Warriors game. I'm just kind of throwing that out there, Chris. But an individual unit moves and drifts around there very, very heavily. And it could be the same condition. It could be the same unit, but different conditions, different staffing, the different acuity of diseases or issues that come up, that changes this dynamics very, very considerably. It's very similar in a certain sense of kind of like that frozen pond or that frozen lake. Think about everybody was out there during the day and it looked like it was safe. But what happens when it gets heated up over 2 o'clock, 3 o'clock in the afternoon? What if there are different people skating on the ice? The conditions and the environment always change. And when we think about the work as done, in other words, really, what are the things that are happening within that envelope of safety? We have to really understand that the margins to the people with doing the work and the margins really looking at it from hindsight bias, it's not very clear. So we have to really kind of go in, ask our people with that level of psychological safety, just like what Tina did, and really allow people to come out and tell us what's actually happening in that black box. So really, when I talk about this black box, is the same picture as before. Don't worry about the black box. But I want us to start moving towards thinking about what is it just culture, think, and how can we become a just culture now that we understand the dynamic nature of drift within these boundaries of work? Sidney Dekker said, the main question for a just culture is not about matching consequences with outcome. I'm going to say that one more time. The main question for a just culture is not about matching the consequences with the outcome. It is this: did the assessments and actions of the professionals at the time make sense, given their knowledge, their goals, their attentional demands within their organizational context? I think it's a very profound statement, that Sidney Dekker really kind of shares, is really, if we're thinking inside the black box, the knowledge, their goals, their attentional demands, and their organizational context, how does that all weave into what's really happening inside where work is being done? Thinking outside the black box is really our job to move towards a safety culture. So then Professor Dekker then asked this. He says, the question that drives safety work in a just culture is not who is responsible for failure. Rather, it asks what is responsible for things that go wrong. So it's really, again, the fundamental attribution. We have to move away from that tendency of addressing who screwed up, just like what happened with Tina and the scale. But really, we have to step back and really ask, what were the conditions? What were the situations? What was the system that an individual who is a human being doing their best job made, which caused an unexpected and an unexpected outcome? What is a set of engineered and organized circumstances that is responsible for putting people in a position where they end up doing things that go wrong? So again, very powerful statement by Sidney Dekker when we're thinking about just culture. One of the ways that I think you can really harness and work towards a just culture really is kind of taking a note from what we've learned in commercial aviation. Commercial aviation, fortunately, and this is actually a pyramid that was created by an industrial expert in accidents back in the 20s and 30s. Of course, correct me if I'm wrong. But just to create kind of a framework for understanding, for one accident, one plane crash, one whatever it might be, there are numerous other opportunities to recognize that there are factors that potentially had driven towards just that one accident that may have gotten everybody's attention. Within aviation, a lot of effort is really focusing on analyzing near misses. This is a book by Colin McRae, who writes a lot about organizational psychology and very involved in aviation safety. Chris, I think you've actually met and had interactions with him before. And one of the areas I really focus is, for that one fatality, how many near misses actually could we or can we learn from before we start to actually to get to an incident where somebody is actually getting harmed, so that we can move towards a place where we're now being able to avoid, to the best of our abilities, mitigating serious injuries or, God forbid, fatalities, in which all of us become second victims and third victims and multiple victims on top of that, really moving towards that near miss. This is a tool that my wonderful partner, who I hope should be on the line right here, Tamitha, and my predecessor, Dr. Jeff Commissar, really helped develop for our organization in Kaiser Permanente. And it was actually really how to be able to approach, even through this algorithm right here, how to be able to address your education and your training in a way that allows variety of cohorts of people within your organization to understand and know and really glean the opportunities of reporting near misses and events. And really our outcome, remember we're looking for an outcome, is that our employees report safety incidences, including near misses, using a relevant process. So really it's one thing to say, hey, we should just report near misses and events, but really there has to be an operational process for doing so, and how to be able to use education in a very intentional way so we're able to learn from it regardless of who or where we are, where we stand from the organization. So it's always worthwhile really for you to ask, if we're reporting near misses, if we're sharing near misses, what is the right way of going about doing it so we're really able to learn? Because of course this, goes back and disseminates from what I said, really happens and what keeps aviation with the safety record that it really does. I think some of the recent events with Boeing, with both the AI-enabled MCAS system that happened in the original MAX crashes and the recent events that happened, recognize that really complex systems really still are very, very difficult, and there's no perfect way. But I think learning from close calls and near misses really does move us in that direction. So I'm almost done right here. This is actually, I think, my second to the last slide. So we talked about near misses. We talked about blame. We've talked about understanding just being important, the importance of looking at the boundaries and the margins of the way people do things within an ecosystem that's very complicated. I want to just finally emphasize that if you're moving or talking about a just culture, and this is an algorithm our organization uses, hopefully your organization has one. I think there are numerous just culture, algorithms. Whatever tool that you use, in many ways, use the tool as a way to be able to address when you do see drift, not necessarily drift that is bad drift or good drift that is good drift, but just looking at drift. And really start almost with the assumption, that there is unfortunately at-risk action or at-risk behaviors that most people just don't realize. Because if you look back, the box that kind of goes into this at-risk action is, did the person perceive the risk? Well, we look at all those skaters on the pond. How many of them really perceive the level of risk that they might be putting themselves or their kids while they're sitting on the ice, skating along with everybody? It's all hindsight bias, just like what Chris was talking about. So using a just culture algorithm, not necessarily only to grade if something happened bad that you need to find whether it was a system-induced human error, or if it was an at-risk action, or if there's unfortunately malignant behavior that led to reckless action, maybe use it backwards. Use it in a proactive way. Take a near miss, run it through the algorithm, but start backwards and ask people, hey, could this have happened here? Do we have the same vulnerability in our systems? Our organization took the very, very unfortunate public case from Vanderbilt University and ran it actually through our Just Culture algorithm. And every year we run our training program with all of our risk and our safety leaders to really help them understand how to use the Just Culture algorithm in a way to be able to identify proactively so we can get to that generative space, of being proactive and creating that culture of safety that is so important. So really, whatever tool you use the tool to look at your near misses, maybe use your tool to look at other events that it may have happened, and really allow people to be able to speak up and bring that level of awareness and psychological safety with whatever tool you happen to use. Because ultimately, these tools really allow you to be able to systematically build towards a culture of safety, just culture, and also really everybody understanding what their risks. I want to also bear in mind that all of this was very complex and deep, hopefully insightful information. Dr. Chris Lemaster and I shared. It takes time. You could see even our to Ura's human journey has not necessarily been a straight line. We can see very clearly, that our patient safety movement, and from 1999, it's been a lot of twists and turns. But I'm just so thankful that you've had myself and invited myself and Dr. Lemaster to kind of share that. Hopefully, as we are working through that curvy blue line, maybe over in the middle, that we do find that there is a way out, and hopefully being able to, see that together collectively as a community. So with that, I'm going to stop sharing and take it back to Rachel.
Thanks. That was a great presentation. I know a lot of valuable information and getting us to start shifting both the individual mindset and organizational culture. So lots of good stuff. I think we have time for one question. And this did kind of start in the chat, I noticed, but really a good thing to walk away with today. What are some strategies you guys recommend for bridging the gap between work is done and work is imagined? I know we talked in the chat, there was some discussion about, being on the floor and documentation. So what are some suggestions you guys have?
Chris.
All right, I can go
Love
first.
the world.
I think, I come back to how we think, how we're thinking about the problem, because sometimes walking the Gemba can be a marketing maneuver, right? You can go to a place, but how you interact with the people there has everything to do with how you think about them. And so if you think that you should walk the Gemba, or that you need to make people feel like you're on the floor more, that's all that will serve. But if you actually want to listen to them and you see them as expert, that again, nurses have lots of emotional intelligence. They can sense when you're not being sincere. And so this is why I think it really does come down to wanting to engage with your people, being curious, like, hey, these people have a ton of stuff to teach me. And I have to say, every time I do this with an adverse event, I learn something new, something I had no idea about that only the frontline staff told me. And often we're wading through blame, so to get there. So I think to me that's paramount. Jason?
Yeah, no, I completely agree. And I think if there's one message that I would have, whether we're talking about, drift or psychological safety or just culture, these are all words that seem very, common sense. But really, unfortunately, I think it takes time and it takes some intentionality to really listen to what is the effect words are actually having on the psyche of people, to really think, potentially needing to take a word such as like drift, or, whatever, or error, for instance, and really kind of understand the psyche of how those words play into people's ability to be able to speak up. And being free and open. And that's the reason, again, why I love, and Chris, shares a story of Tina, how she took time to respond and react, in an appropriate way. It's almost against our human nature. If you saw a picture of the cats, let's blame the dogs, right? Let's blame, blame, blame. I think, it really does show you how much we really need from the top all the way to the bottom, but more important, the bottom all the way straight up is really how the effect and the psyche that words have, on the way that we react.
Excellent points from both of you. Yeah, we can all tell when we're just going through the motions and it really doesn't serve anyone. So, Chris, did you have last thoughts to add?
I just had one other thought, and of course, it escaped my mind, but thank you, Kathy, for bringing this up. Learning teams is a great way to think about this. So this is the way in which Todd Conklin was able to operationalize the human and operational performance concepts, those 5 principles I talked about, and what Bob Edwards did at Chevron. It is, it's basically how to do that in whatever work setting you're in. And I've been doing this with a number of staff in our hospital for several years now, and it has been transformative. I mean, it's been just a lovely, lovely thing where people are like, oh, that's what they saw? I had no idea. And then they 180, we've had union reps who were speaking for nurses who didn't feel free speaking up. And by the end, they were thanking us for engaging with them. It can be incredibly powerful. I'm happy to provide any resources for folks who are interested in learning more about learning teams or human and operational performance.
Excellent. Yeah, we will, that wraps our presentation for today. So we will be sharing the recording of today's webinar along with the slides on our website. We will email everyone when those are available. When the webinar closes today, you will see an evaluation request pop up. Please, if you have just a quick couple minutes to fill that out, we very much appreciate your feedback. It helps us improve our future offerings. And then just a last reminder about the available CE credit. Be sure to text in the code LANDEQ to the phone number 919-213-8033. If you had any questions that didn't get answered or any additional questions you would like answered, please reach out to us and we will get you connected with Dr. Lemaster and Dr. Chang. And with that, I will say goodbye and enjoy the rest of your day.